Professor Guagliumi mentioned it a lot of times. This whole session and my talk stands at the limits of evidence-based because we don't have enough evidence. But let's see what we have. So there's there are a lot of data on imaging use for planning of PCI with DES. But there are very few data what to do when we're using DCB. If we see this classic consensus from 2020 on how to prepare a lesion and how to choose our balloon to vessel size, they suggest 1:1. Then they talk about no flow, limiting dissections. They talk about the use of imaging, but they don't clarify how to use it. If we go back in the very first session where we talk about the basics, the way to use imaging in any case is to do imaging pre and assess the plaque morphology, the length and the length of the lesion and diameter of the vessel, as Andreas just showed. And then when we do imaging post-stenting, assess things like expansion apposition. They don't exist when we don't use stents, obviously, but also test about medial dissections. And let's see how all these things translate to the existing at the moment evidence. About the lesion preparation, obviously it is necessary to do lesion preparation with calcium modification technologies when there is calcium. When there is no calcium, like in this case, and especially when there is lipid, it's a bit more provocative what to do, and that was the question from Labis. And this was the answer from Andreas. He referred to this study where a Dutch group used NIRS-IVUS to detect lipid-rich plaques, do a DCD and DCB with paclitaxel, and then reassess after a few months and show some reduction in the lipid plaque. Of course, I think that was like 30 cases. So it's a very experimental concept that we need to see a lot of more data before being convincing. What we know, though, and we can see that in this study, the Ultimate 3 study, which used IVUS to guide DCB PCI, is that you will have better results on late lumen loss and on diameter stenosis. And how do you achieve it when we use IVUS? We use larger balloons. You see here that there's a difference. Someone can say that it's a small difference. I can answer that for small vessels, 0.25 is not that small. So that makes a difference for these vessels. But now if we move to the sensitive subject on how to size our balloons, we'll see that this is not really clarified. And let's take, for example, the Transform 1. Transform 1 compared Magic Touch, this is a rolling balloon, with the sequent paclitaxel balloon. And as we can see here, I will explain this, this figure, they used different protocols. So for the for both of them, for both sizing, they used lumen, not external elastic lamina. But they did a different kind of upsizing that led to smaller balloons when they used Magic Touch and larger balloons when they used paclitaxel balloon, the sequent, and that was because of the compliance of the balloon. So these tools are not, they don't fit at the same size. They are different. They have different, it's not only the drug, they have also other features that they are different that they will have to take into account. Now, if we go to the post-DCB assessment and focus on the dissections, let's see this consensus, this Japanese expert, as they state consensus. Use IVUS and OCT, and if there's a dissection above C, then, or a medial dissection, then proceed to bail out stenting, which is not what we saw, which is not what is supported by the emerging evidence that Professor Guagliumi mentioned. So we have these two studies. One is larger, a few hundred patients, and talks about the target lesion failure probability, and we have another one smaller that talks about the remodeling of the vessel. And both say the same thing. The larger the dissection, the medial dissection, or even a dissection that affects the adventitia, leads to better results. And this is the case because maybe you leave more space for the drug to interact with the vessel wall and create this positive remodeling at a short follow-up. But just to close, I think this is my last slide to make it a bit more complex. Again, it's not the same for all balloons. I go back to Transform 1, and you can see in Transform 1, and we can see it here, that when we take the Magic Touch balloon, the existence of dissection was unfavorable. The larger the dissection, this dissection volume, the late lumen loss was larger. This is the Magic Touch line. On the opposite, for a paclitaxel balloon, the larger dissection, the smaller the late lumen loss. And I conclude here. I think there are more questions than answers. It's a very interesting field for more research. Thank you very much.
Thank you. Thank you also because it bridges the previous case, clinical case, with what do we know today in terms of evidence. Very, very important. Okay, let's proceed again.
Let's go, thank you very much, to the second case. Ms. Pappa will make the presentation.